Hi, welcome. My name is Dr. Kaja, and we're going to go over sleep disorders in the elderly, and this is part of the Geriatric Workforce Education Program of in South Florida. Learning objectives. The goals of this talk are to understand the extent and scope of sleep disorders in the elderly, physiologic changes that occur with aging, common pathologic manifestations, and diagnostic and treatment modalities for sleep disorders in the elderly. The epidemiology of sleep complaints amongst the elderly is well documented since at least the 90s. There was the famous EP-ESE multi-center study that showed that complaints such as trouble falling asleep, waking up, early awakening, needing to nap, and not feeling rested were quite common in this age group. Less than 20% of the participants of this study had no complaints, and over half of them reported at least one of these complaints as occurring most of the time. Between 23 and 34% had symptoms of insomnia, and 7 and 15% rarely or never felt rested after waking up in the morning. Symptoms were associated with increasing numbers of respiratory symptoms, physical disabilities, non-prescription medication use, depressive symptoms, and poor self-perceived health. This causes quite a lot of morbidity in this age group, and that's part of the reason why we need to look into this more deeply. Changes in sleep with aging. Total sleep time decreases throughout life from 10 to 14 hours per 24-hour period in the pediatric age group to approximately 5 to 7 hours in the elderly. This natural shortening of their total sleep time is, in some older adults, may generate unrealistic expectations about how long they should be sleeping. For example, somebody who's used to sleeping 12 hours a day suddenly only starts waking up after 6 hours of sleep, and they may find that this causes some concern for the patient. Beginning in middle age, adults start to spend less time in slow wave sleep. Changes in the circadian rhythm influence many elderly to go to bed earlier and awaken earlier. There's also increased sleep fragmentation, as well as the frequency and duration of daytime naps tends to increase. Diagnosis of insomnia in the elderly. Sleep history. As with any other field of medicine, onset, duration, pattern, and severity. We can also evaluate 24-hour sleep wakefulness patterns, review a 1 to 2 week long sleep diary, interview the bed partner, review family history, identify potential causes, and to see if there's any emerging patterns about why this might be happening. Some common causes of chronic insomnia can basically be characterized into 3 groupings: physical illness, primary specific sleep disorders, and medications. Of physical illness, particularly of interest in the geriatric age group is chronic pain, and for primary sleep disorders, we can look at circadian rhythm disorders, sleep apnea, and RLS. Medications are also an important cause of chronic insomnia in the elderly. 3 major classes of drugs we should be paying attention to are CNS stimulants, antidepressants, and anti-Parkinsonian agents. And we'll be going over some of these topics in detail further down in the presentation. And how do we approach the management of insomnia in the elderly? Along with the physical and laboratory investigations, there should be a discussion of expectations of what the treatment plan might yield and how good outcomes can be or how they might not be all that good. Obviously, we also want to include treatment of sleep hygiene, non-pharmacologic measures, and pharmacologic intervention should all be considered depending on the patient. Sleep hygiene and non-pharmacological measures fall into actually 2 separate categories. For non-pharmacologic measures, we're talking about behavioral therapies, which can be cognitive behavioral therapies as well, stress management measures, progressive muscle relaxation to reduce somatic arousal, lower pre-sleep cognitive arousal, and reduce tension and anxiety. For sleep hygiene is to avoid and minimize the use of caffeine, cigarettes, stimulants, alcohol, increase exposure to natural light, decrease exposure to natural light in the late evening and increase it during the day. Avoid napping, and particularly after 2 p.m., and avoiding heavy meals at bedtime. Pharmacologic interventions. Principles of pharmacologic intervention in this age group are the lowest effective dose, use of intermittent dosing, short-term use, gradual discontinuation to prevent rebound insomnia, and having an understanding of expected pharmacologic outcomes with the patient, and coming to a pre-treatment agreement of when treatment should be terminated, at what mile markers that the patient and the physician need to agree to. Some pharmacological options are benzodiazepines and non-benzodiazepines, including zolpidem, zalpolon, isopicolone, and indapolone. Antidepressants, as well as MT1 and MT2 receptor antagonists, are also options. Principles of rational therapy: lowest effective dose, intermittent dosing, short-term use, and an agreement to discontinue. Benzodiazepines are effective at reducing REM sleep. They decrease sleep latency. They decrease nocturnal awakenings. Characteristic rebound insomnia in 1 to 2 weeks with the use of benzos. For non-benzodiazepines, we can look at omega-1 benzodiazepine receptor inhibitors, such as zolpidem or zalpolon, as well as trazodone, MT1 and MT2 receptor antagonists. Behavioral therapy goals: changing maladaptive sleep habits, reducing autonomic arousal, alter dysfunctional beliefs and attitudes that can perpetuate insomnia. And these are some of the important goals that we need to set. And the types can fall into progressive muscle relaxation therapy, which reduces somatic arousal, attention focusing techniques, which reduce cognitive arousal, sleep restriction, stimulus control, and bright light therapy.